introducing a personal hero of mine and sharing her brilliant mind with my Google family. As many of you know, I was diagnosed exactly 1 year ago with breast cancer and fortunately labeled no evidence of disease this past July. Yay! My current good health and the good health of many could be attributed directly to individuals who are pioneering, innovating, and driving change in the breast cancer landscape, in particular, the one you'll hear from today. Dr. Susan Love has dedicated her professional life to the eradication of breast cancer. As the Chief Visionary Officer of the Dr. Susan Love Research Foundation, she oversees an innovative research program centered on breast cancer cause and prevention. She is also a clinical professor of surgery at UCLA's David Geffen School of Medicine. Dr. Love is well known as a trusted guide to women worldwide through the Foundation's Inpatient Science Education Program and her books, including the Breast Book, which is now in its 6th edition, and it's back there, and she's available to sign the books as well after the talk. The Foundation's recent groundbreaking initiatives include the Army of Women, developed to partner women and scientists to accelerate translational research, and the Health of Women Study, an online cohort study aimed at identifying the cause of breast cancer. Among the Foundation's collaborative research projects are the development of an NIH-funded self-reading ultrasound technology for triage of palpable breast lumps, an analysis of the anatomy of the breast ductal system, and an investigation into the microbiome of breast ducts. Dr. Love received her medical degree from SUNY Downstate Medical Center in New York. She trained at Boston's Beth Israel Hospital, was an early member of the Multidisciplinary Breast Center at Dana-Farber Cancer Center, and founded the Faulkner Breast Center and the Revlon UCLA Breast Center. She received her business degree from the Executive MBA program at UCLA's Anderson School of Management, so she's quite impressive. So please give a warm Google welcome to Dr. Susan Love.
Thank you so much. It's great to be here, and it's great to be here particularly because it's not, I didn't even have to come that far because I live on the west side. So normally it's a big thing to travel somewhere, and this was easy. So I really appreciate it. And I know I saw there were some questionnaires put out or some questions put out ahead of time, and it sounded like everybody wanted to know how to prevent breast cancer. But the answer is we really have no idea. I wish I knew, but we really don't. It's not as easy as the HPV vaccine. When I was young, if people had cancer that had an abnormal pap smear, actually, they had a hysterectomy because we didn't know what else to do. We didn't know it was caused by HPV. We didn't know how to prevent it. And now we have a vaccine. So we can figure out how to prevent cancers. It is possible, but with breast cancer, we really haven't come even close to that. We know, and a lot of you, I'm sure, have heard ad nauseum the risk factors for breast cancer, and that gives you kind of hints. Some people have a gene that they inherit, a mutation that they inherit from their mother or their father that makes them more at risk for breast cancer. Most men with breast cancer actually have an inherited mutation. And it's interesting because as they're doing more research, recently, we found out that not only is there the mutations that we first discovered that were more common in people of Ashkenazi Jewish descent, but there's actually an African American mutation that tracks back to Western Africa before the slave trade. Because one of the things about breast cancer is you don't get it until you're at least in your 20s. And so therefore you have time to reproduce before you get the disease and die. Whereas a lot of diseases that you inherit, you die before you have time to reproduce, so they're not as prominent. But breast cancer, you actually have time. There's also a mutation, a Latin American Hispanic mutation that tracks back to the Aztecs. And there's new research going on in the Asian American community looking for mutations there. In fact, there was a report out yesterday that they found 50 new mutations, potential mutations, that may track with breast cancer that they were previously unaware of. So some of it is having something in the DNA that makes you more susceptible. But most people who get breast cancer, the vast majority, really have no mutations. It's not hereditary. It's just bad luck. Now, we know that hormones have something to do with breast cancer. We know that people who have their first period young and they have menopause late, so the more years they have with hormones, the higher the chance of getting breast cancer. We know people who take hormones after menopause, which used to be really common, to prevent aging and have more breast cancer. So we know that hormones are related to it, but we still don't know exactly what and how. We know that never being pregnant increases your risk, or having your first pregnancy late, and late, I hate to tell you, is over 30. But it does increase your risk. But all of these things are just risk factors. They don't say you're going to get it. They just say that when we look at large groups of people, we find that the people who fit in this category have a higher risk. Dense breasts on mammogram, not breastfeeding, which we'll talk a little bit more about, and hormones after menopause, all of those increase the risk. But why do they increase the risk? We have no idea. Now, the problem, the reason that we have no idea is the way that research is done. I mean, what we tend to do is we observe things, we make a hypothesis, and then we test it. So, for example, initially, when I first started in breast cancer work, we observed that people with big cancers died more than people with little cancers. So therefore, we said, let's do early detection. If we found it when it was little, we could prevent it from spreading. And maybe it just grows a little bit one by one, and then it gets to a certain size, and then, oof, it's out. So what if we find it really early? And that was the beginning of first breast self-exam and then mammography screening. In actual fact, breast self-exam has been found not to make any difference in the outcome of breast cancer in a large randomized controlled trial. And early detection sort of works, but not perfectly. Because it turns out you can have small cancers that are very aggressive, excuse me, and then you can have larger cancers that are sort of indolent and aren't going to do anything. So size is not the only factor. You also have to look at the cells and whether they're going to spread and other factors as well. And for a while we thought, well, maybe if we just do a big operation, and if we cut the breast off, take all the lymph nodes, we could slam the door and prevent the cells from getting out. That's the way. And when I started, we were still doing radical mastectomies, where we took the whole breast, all the lymph nodes, and even the muscle, the pectoralis muscle out, with the idea that the bigger the better, we would do it. But then it turned out in randomized controlled trials that lumpectomy and radiation, taking the lump out and radiating the breast, works just as well as a radical mastectomy. So obviously, and now the studies are showing why this is, because the cancer cells get out really early, way before you can detect it on a mammogram, way before you can, you're going to see it, you're going to feel it. And so you're slamming the door, but the horse is already out of the barn. And so that's why more surgery really isn't better. We actually had a study where women agreed to be randomized whether they got a lumpectomy and radiation or a full mastectomy. And so they picked out of a hat which treatment they were going to have. And they did that so we would know this answer. And they followed those women for 20 years, no difference in the outcome, whether you took the breast off or just took the lump out and radiated the breast. So it sort of is, it gets me, because now we've gone back to everybody having mastectomies or double mastectomies, when in actual fact, unless you carry the gene, a double mastectomy doesn't really buy you anything. It's just more surgery. And the problem with mastectomy and reconstruction is you don't have any sensation. So when we do the mastectomy and we make the new breasts, they're completely numb. So you hug somebody, you can't tell you're hugging them. It's just like having two lumps there. So we really, we have science, and it drives me crazy that despite the science, and we just had somebody, yet another famous person have double mastectomies, that we're still in an area of fear. It's sort of like, if your hand betrays you, cut it off. If your breast betrays you, cut it off, and we'll maybe cut both of them off, and maybe I'll live. But actually, it's not the way cancer works. Those cells are out really early, and that is why, in addition to what we do surgically, we also give drugs. We either give chemotherapy that can circulate around and find all the cells and kill them, or we give hormone therapies that can make the cells become dormant, or we give targeted therapies that can block the growth of the cells. So you have something to take the initial lump out and then something to take care of the rest of the body. And that combination has really improved the survival significantly. So when I started, most people died of breast cancer, and now most people don't die of breast cancer. Most people, we're able to cure the majority of people with breast cancer, and with a combination and the right treatments. But we still don't know what causes it. We still don't know how it starts in the first place. Now, the majority of breast cancer probably starts in the lining of the milk ducts. And the breast is sort of but the problem is that most of our research goes on in rats and mice who don't actually have the same breasts that we do. In fact, they don't have breasts at all. They're flat-chested, and then when they get pregnant, they make breasts, and then they go flat again. And so we have to humanize the rats and mice in order to study them. And instead, we really need to study humans, which we tend not to do because they're too expensive, too hard to find, and it takes too long. That's what the researchers say, at any rate. But in fact, breast cancer is unique to humans. Us and domesticated dogs and macaque monkeys are the only ones that get breast cancer. So if we don't study us, we're not going to figure this out. Now, the human is very unique. The woman's breast is very unique. It's the only organ you're not born with. You're born with a nipple and stem cells behind your nipple, but that's it. All your other organs, your lungs, your liver, they're fully formed when you're born. Your kidneys, they're all there, but not the breast. The breast, you just have a nipple and you have these little stem cells. Then puberty comes, and like those sponge animals in the capsule that you put in water and they turn into a, duck or something. Well, the hormones come and the breast sort of blossoms, right? And the stem cells grow back and you make this breast. And you have ducts that carry milk to the nipple, and you have lobules that make the milk, and they're suspended in a stroma, in a context that's holding them up. So it's sort of like, I don't know, having fruit and Jell-O, the ducks are sitting there in the stroma. We're the only ones that have that. All the other animals don't have stroma, and we're really one of the only ones that has breast cancer. Now, once they're developed, they're at the ready to make milk at a moment's notice. So every month when you have your period, they're saying, is this the month? Are we going to be able to turn into a milk factory this month? No, forget it. Is it this month? No, forget it. And then finally, so there's all those changes. And then finally, you do get pregnant. And then they turn into a milk factory. And they can turn blood into milk, which is pretty magical when you think about it. And not only can they turn blood into milk, but the milk changes depending on the age of the kid. So the milk for a newborn is different than the milk for a 6-month-old or a 9-month-old. And it actually adapts. And if you have twins, you make twice as much milk. It's a supply and demand kind of thing. You also give your immune cells through the breast milk. So you not only nourish the kid, but you pass on the immunity of the breast milk through the breast milk. It's a very magical system. And then at the end of breastfeeding, massive cleanup, involution, all the ducts, disappear, they get cleaned up, and you make new ducts for the next kid. Are they in the same pattern as the first ones? I mean, is there like a channel and they fill in? Or do you make a whole new pattern? Are there extra stem cells behind the nipple that grow back? We don't know. Nobody's ever looked. We don't actually know the anatomy of the ducts. We don't know, how many. I mean, I have some ideas. I think it's about 6 to 8, but we really haven't mapped. It's the only part of the body that we haven't mapped. We've mapped the lungs, we've mapped the liver and the bile ducts, we've mapped, everything else, but the breast, we don't have a map of. So we can't map where breast cancer starts. We think it starts mostly in the duct and in the lobules. There are occasional cancers that can start in the surrounding tissue as well, but we don't know for sure. Yeah,
Why don't we have a map?
because nobody's bothered to do it. Because rats and mice have one duct per teat. So they have a, they have a nipple, they have one duct. So you don't need a map to show what it is in relation to anything else because there's only one. We have 6 to 8. I think there's 2 or 3 in the middle that go straight back and then the others drape around. And we've done some initial work on that, and I'll talk about that a little bit more too. But we just we don't study women. It's crazy, actually, when you think about it, but we don't. And if we could figure that out, maybe we could prevent it. I mean, we know, as I said, that most of it starts in the milk ducts. If it starts in the milk ducts, why couldn't we figure out something like Drano, squirt it down the duct and clean it out? It's like rust in the pipe. You could put a treatment introductorily. And we've actually tried that. In rats, it works pretty well. And I've tried it in women, both in China, in a study that we did in Beijing, and in another study in Northern California. But what we did it in women who were going to have mastectomies anyway, so that we did it first, and then a couple of days later they had the surgery they were planned to have, because I wasn't sure what was going to happen, whether the breast would turn black and fall off or something. I wanted to make sure that we knew what we were doing. And then it was fine. It was easy, and you can numb up the nipple very easily. The nipple itself, not the areola, is very tough because it's made to be chewed on by babies and lovers, and doesn't really have much sensation. And it's the areola that's more sensitive. And so if you just stick to the nipple part, it actually doesn't even hurt to do that. So you could do that, or could you put something else down the ducts and clean them out? Or destroy the stem cells? Could you put a microwave? And we've talked to some people at USC who have some ability. They think you could do that. And maybe we could microwave the lining of the ducts so you wouldn't get cancer. And maybe they would get stiffer, and then everybody would get an uplift at the same time. Then we'd really have something. But the problem is that we don't have this research because of the research on rats. And so we've been working on this, and we're trying to do this map, and we've worked on, so I decided, well, and this just shows you how science goes. I said, what about lactating women? Then they've got milk in their ducts. So then we could ultrasound them, we should be able to see them. So we recruited 10 lactating women, told them to bring their babies and come full and then breastfeed. So we did them full and empty, and we did whole breast ultrasound with the idea that then we'd be able to see the milk in the ducts and we could do a map. And we actually roped in the Jet Propulsion Lab to help us with the images. Because it turns out that JPL has to prove that some of their technology also has other utilities besides science, besides space. And so they're very good at fuzzy images, actually. So we just, as long as we didn't talk about nipples and breasts, they were okay. Map the rivers in this mountain. But what we found was really interesting, and nobody had figured out before. Not all the ducks were making milk. Now, I was always taught that when you breastfeed, all your ducts make milk, and then if you have twins, you make more milk. It's a supply and demand system. But actually what we found was that the people whose babies were only 1 or 2 months old, only one duct was making milk. It was the lower outer duct. And then over time, the people who were maybe babies were 4 or 5 months old had more ducts. So you actually pull more, you recruit more ducts as you need them, rather than have everybody making milk and then making more milk if you need it. And the last one you recruit is the upper outer. Now, the reason that that's so interesting is that that's the one that gets the most cancer. And we do know that people, if you breastfeed, you can reduce your risk of cancer, but you got to breastfeed 6 to 9 months. And that's probably because you don't use all the ducts until you breastfeed long enough. And then at the end of breastfeeding, remember, you have massive cleanup. So if you've acquired any mutations in these ducts, you're going to wipe them out. And it's sort of like erasing the blackboard. You can start all over again. So that may well be why that's protective. So we're trying now, we're going to try to do another study on, more longer breastfeeding women, see if I can get my map. I still didn't get my map because they didn't all have that. But that's how science goes. So now I'm going to try industrial strength breastfeeders. My sister was like that. She breastfed for like till her kid was 2 and said, I'm finished, mommy. I don't need to do this anymore. I'll see if I can get people like that, if we can get a better map. And my fantasy is ultimately we'll have a 3D map of the breast. I'll come back and show you when I get it. And then the reason this is so important is because breast cancer starts, as I said, in the lining of the duct. So if you had a map and you knew which duct was bad, you'd know where to go. You'd know where to operate. You wouldn't be just blind, or you could squirt something down. But because we don't have a map, we can't do that. And that's one of the reasons we end up doing bigger and more surgery. The other thing we looked at with the Jet Propulsion Lab is the microbiome of the breast. So when they did the Human Microbiome Project, where they looked for all the bacteria and viruses, and this is because we have new technology now that we can map all the DNA and RNA, subtract the human DNA and RNA, and see who's left. And so that's why you're seeing all the microbiome studies, because you see all this other DNA and RNA that's not human, and you can start to track who it is. Well, when they did the Human Microbiome Project, where they mapped all the different parts of the body, they didn't do the breast. They just skipped it. I don't know why. Boys, excuse me. But I think it just didn't occur to them. And indeed, the breast has bacteria and viruses on it. It gets sucked on at a regular basis, and there's no reason to think it wouldn't have bacteria and viruses. And so in it. And what we found in our initial studies looking in the ducts was that there might be a protective bacteria that actually protects you, that the people who didn't have breast cancer had, and the people who had breast cancer didn't have. Now, if you think in the bigger sense, we remember that people who have pregnancies and have kids have less breast cancer. So theoretically, and people who breastfeed have less breast cancer. If those bacteria and viruses are getting in the breast because somebody, babies, lovers, whoever, is sucking on their breast, then maybe, if you were God or Mother Nature, you would want the people who reproduce to live, and you wouldn't care about the nuns who have the highest breast cancer and theoretically have the least sucking on their nipples, although I haven't checked. But they also haven't had kids. So, but, so it might make sense, in fact, that there's a protective bacteria, is my point, from an evolutionary standpoint, that you would want the people who reproduce to be around to not get cancer and die, but to be there to take care of their kids and raise them. So from an evolutionary standpoint, that might make sense. And we're going to be pursuing, and that one we did with the Jet Propulsion Lab also, because they have a department of planetary protection. So that we don't put bacteria on Mars and Venus and things like that. And so they're very good at mapping these things. And that one of the keys that people haven't thought about is you can map all the DNA and RNA, but it doesn't care whether it's alive or dead, right? It's just DNA and RNA. Where some people did this study in the OR and they found more bacteria and viruses. They didn't realize is in the operating room, our definition of sterile is it won't grow on a Petri dish. Not that dead bacteria we don't care about in the operating room. So they mapped a lot of dead bacteria without thinking about it because they didn't really think about the difference with the operating room. So at any rate, just shows you how interesting science is when you do it. So that's some of the work we're doing. Other work that we're looking at is the one that was mentioned, that our triage system. So in most countries other than the US and Europe, breast cancer is a premenopausal disease. Partly because it's genetic, partly because the other risk factors that lead to postmenopausal disease aren't there. Like they don't take hormones after menopause, they tend to have early pregnancies, which is protective. They tend to breastfeed more, which is protective. And there may be other factors, even environmental factors that we're not aware of. But in premenopausal women and women before menopause, breast cancer is almost always a lump. One is because mammography doesn't work very well in that group. And secondly, because it's sort of a different kind of cancer. It's one that grows in when there are hormones around, as opposed to one that grows when there are no hormones around. And Most lumps, however, in young women are benign. 9 out of 10 are benign. And our response to the hormones. So the majority shouldn't need to be treated if you knew they were benign. They're cysts or they're fibroadenomas. They're easy to tell the difference on ultrasound. They're not very easy on mammogram, but they're very easy on ultrasound. So our idea was to develop use artificial intelligence to develop a computerized algorithm that could figure out, triage, which ones you had to pay attention to and which ones not. And we did our first study. We got an NIH grant, and we did it at Harbor and County USC, which are sort of like low to middle income countries, actually, in terms of the population. And collected a lot of images, fed it into the computer, and we were very accurate. We were more accurate than the radiologist, actually. But these are palpable lumps, remember. So this is sort of like the face recognition where you're standing in front of the camera and it says, oh yeah, it's you, as opposed to the TSA. Mammography is like the TSA. You're looking at millions of breasts and trying to find the one that might have something. This is people who already have lumps, but it's very good. So now GE has lent us their small ultrasound, looks like an old flip phone, and we took it down to Mexico. And I, who am a surgeon, not a radiologist, taught 3 low-level healthcare workers, a first-year medical student and a nurse and a first-year OBGYN, how to do it. And their images were as good as the radiologists, and the computer could read them all very accurately. So we're now testing it in Tijuana and Guadalajara. And in Tijuana right now, or in Guadalajara, it's a 9-month wait for a diagnostic ultrasound because they don't have enough radiologists. So really, globally, I mean, this would make a big difference because it's this about, it looks like it's not very big. You could have it in your backpack, and the people who are doing healthcare in clinics and around could just, pull it out, hold it over the lump, say, no, you're okay. Because 75% of them are going to be totally benign. And you could leave them. You don't really have to do anything if you know they're benign. And so we're working on that. The interesting thing is, and this is the first world, third world dilemma, GE, who's been helping us, at least with the machine, said, yeah, but who would be the customer in the United States? Because they don't want to lose the radiologist who is their customer. And this disintermediates the radiologist. So we said, well, what about, the OBGYN? That's where young women go with their lumps. What about Planned Parenthood? What about, the Women's Health Clinic? They're like, but they haven't bitten yet because they're too scared. And this thing, you don't even need the cloud. This is just an app right there because it's really straightforward. So we do a lot of that kind of stuff because I think unless we start, if we keep trying to take what we do here and exporting it around the world, it's just a lot of expensive healthcare and overdoing. And we really can leapfrog that and jump into much better ways of approaching things if we're willing to be creative and try to do it. So the combination of figuring out breast cancer is really going to be, has to be focused on understanding the human breast, and has to be how can we take advantage, learn about the human breast, and then take advantage of that to prevent the disease in the first place. And in order to do that, we need a lot of people who are willing to be in research. So we at the foundation developed the Army of Women, which also has a few good men in it. But we figure since we've had to be part of mankind for a long time, they can be part of the Army of Women. And in the Army of Women, what it is actually, it sounds very fancy, but it's a big mailing list, email list. And researchers come to us with their studies, and we e-blast them out to everybody. So we don't select, we don't try to match, because what we find is you may not fit the study, but your neighbor may be perfect, and then you pass it on. So we just send them out to everyone, and then people respond who are willing to be in the study. And the studies could be anything from preventing breast cancer with exercise to, some treatment for a particular kind of breast cancer or metastatic breast cancer, anything. And then they get virally sent out, and then the people respond to us, and we give them to the researchers. And that way, the researchers have no excuse not to do research on people. Because if they can't find them, I can find them. Now, the one thing about the Army of Women that we're trying to fix is we don't have enough diversity. So during this October, we'll have a big campaign called Commit to Love to try to increase the diversity in the Army of Women. We need more Asian women. We don't know enough about breast cancer in Asian women. We don't know enough about it in Hispanic women. We don't know enough about it in African American women. Almost all the research is done on white Caucasian women. And one of the reasons, again, is the researchers say, well, we don't know how to find them. So we're trying to expand the Army as much as we can to have as diverse a population as we can so that we can actually get the research to represent everybody. And, you know, sometimes you don't need everybody in it. This is something you guys would know more, even better than I. But we had one study for Vietnamese women, and I thought, you know, we're going to have a hard time because we only have about 5 in the whole Army of Women. And we filled the whole thing in a week because we had the right Vietnamese woman, and she knew everybody who had breast cancer, and she got them there. So this is a viral kind of way to do it, but it's the only way we're going to figure this stuff out is if we're willing to be part of studies. And this gives you a chance to figure out whether it's a study that appeals to you or doesn't, and who to do it. So we would love for all of you to sign up for the Army of Women, and you guys can sign up for it too, and you can pass them on as well, because you know lots of people that you could spread it out even further on. And that way, they have no excuse, and we won't be so stuck with the rats. We'll really start to figure out what causes breast cancer in us, and how can we end it. And we have to be the generation that ends breast cancer, because if not us, who's going to do it? So we have to do it. And I ask you all to help me and join with us, and we'll do it together. Thanks. Questions? This is the more fun. Yeah.
I'd love to hear your take, especially given all of your research on prevention, and especially if there are now 50 more genes that are coming out saying that, you know, it's not just BRCA1 or 2 that might cause breast cancer. What are the types of things that we should be paying attention to that make us more susceptible to this? And especially if our doctors are saying, oh, you don't need a mammogram yet, you're not 40. What are the steps that you think would be wise?
Well, some of them are things you know, like eat a healthy diet and exercise. That's sort of the answer to everything. We want something fancier, sexier than that, but actually that's it. The other ones you won't be so happy with, like the pregnant, the better. But that's not always so convenient. And so that's not a good one. If you do get pregnant, breastfeeding for at least 9 months is probably worthwhile. Other things, there are drugs. Tamoxifen, which is an estrogen blocker, is a drug which has been shown in large randomized controlled trials to reduce the chances of getting breast cancer. If somebody is really at high risk, that could be worth looking at. But other than that, we're really not very good. That's why I'm looking, maybe we'll be able to change your biome, or maybe we'll be able to squirt something down the ducts and see if we could do it that way. Now, the interesting thing on the squirting down the ducts, though, is, see, the thing with cancer is it's not just bad cells. It's bad cells in a neighborhood that's egging them on. So it reminds me of a gang in a bad section of LA where you've got a bad neighborhood and you got a gang rising up. You could get rid of the gang, but if you don't change the neighborhood, a new gang will come up. And likewise, you could change the neighborhood, but if you don't get rid of the gang, you're still probably in trouble. But so you're going to need to do both. And at least in rats, when we squirted chemotherapy down the ducts, we were able to prevent cancer for a while. But if they kept the rats alive more than a year, they got second cancers. So we changed, we cleaned up, we got rid of the gang, but we didn't change the neighborhood, which is the tissue around that the ducts are suspended in, right? And so we've got to figure that part out as well. And I think the next thing I'm thinking about is there a way we could combine squirting something down the ducts and maybe a tamoxifen cream or something like that that would do the two things. And maybe, and you know, one of my friends wants to do CAR T cells, which are the sexy new thing, down the ducts. But I'm not sure they're going to stay in the ducts. That's my only worry. So I have to figure that out. But that's what we have to look at. So I think it's going to end up being a combination of some way to change the neighborhood and something to do to the ducts, so that you really can change the whole thing. Yeah. Yeah.
I was wondering if your theory about why, so you mentioned earlier in the talk about how people were having these total mastectomies versus the lump and radiate. Maybe the reason why people were going for the total mastectomies was so that they are not being radiated, because my understanding was that radiation is kind of harmful for the body, and so by doing that, you're basically poisoning the body and like letting it be more susceptible to cancer again. Or...
Yeah, but it's a dose related factor, and it's how it's given. So the way we give radiation now, it's very precise, just to the area, you know, with all the computers and all, you can measure it and just give it to the area that you want to give it. So yes, if you get exposed to just diffuse radiation, then that will cause mutations that can lead to extra cancers. But this has been done now. I mean, we started doing it 30 years ago. So we really have it refined down very well. And what they have found, the problem is you can't cut all the tissue out. And even when you do a mastectomy. So we say total mastectomy as if the breast comes in a little pocket that you could, you know, like a shoulder pad that you could just take it out and then you knew you had the whole thing, but it doesn't. And so even a total mastectomy doesn't get all the breast tissue. And also, you know, it certainly doesn't make a difference in terms of elsewhere in the body. Now, the time when it may be worth doing mastectomies is if you carry the gene for breast cancer. So you know you're at higher risk. And then you might want to have both breasts removed because all the cells carry that gene. And that's a situation where it wouldn't work. But if you have cancer, lumpectomy and radiation is as good or better than a mastectomy, because you can radiate a bigger area than you can cut out. And it's very precise these days. The depth that it goes and all of that is very precise. So certainly I haven't had breast cancer, but that's what I would have, you know, hands down, other than mastectomies. Yeah.
Yeah, that goes back to the scare thing you're talking about. Like everyone's scared of radiation because, you know, that's a dirty word.
Yeah. Yeah. And no, it is. And it's also, somehow people have this notion that, you know, it's like if your hand betrays you, cut it off. If your best breast betrays you by getting cancer, cut it off, you know, and then you'll be okay. But it's just not really thinking about the anatomy and how hard it is to do that, and the fact that the cells are probably out already. So that's why we add either hormones or chemo or something else to get to those cells that may be out already and take care of them. Yeah.
I actually have two questions. The first question, both very simple, is very interested in the flip phone by GE for diagnostics.
Yeah.
Internationally for areas that it's very fascinating. What is the price point on those and the availability for service to utilize them?
Well, we still are doing the phase 2 of our study. So until that's done and we've proven that it works in low resource countries, then we don't know. The actual ultrasound unit is I don't know what the price point is in this country, but I'm sure it's not very expensive to make. The new thing, Philips, for example, the new thing in ultrasound is going to be bring your own device. So Philips has a transducer that you just hook into an iPad equivalent. And then there's another company in Canada that also has a transducer that you can, and I talked to all of them because I need some money to make an app for this so to make sure we don't need the cloud. And none of them are interested in, you know, because they're too worried about the radiologists.
Right. Well, and I think that's what's guessing. So there's been a lot of really great work done by the Blue Zones, and they really understand different parts of the world and a lot of third world countries.
Yeah.
Higher issues of these type of
at
Yep.
a low cost, and I get it, it's all money.
Yeah.
But I find it fascinating and really make an incredible difference in some of these thermal.
Yeah, and I think jumping over with the technology, not saying, let's take what we do here, which is often developed to be the most expensive or to develop the most money, but let's think about what that technology could do in another place, and just sort of skipping ahead is really the way we have to do. I mean, even this, a lot of people are like, well, we just have to, everything's going to be on the cloud forever, but I think not everything has to be on the cloud. You can actually, some of these things you can do really easily just in the device itself.
And we keep information about that on the website.
We do, yeah, and I'll give you a card or something. We'll give you some more information about it. Be happy to.
I have a question. So my mother-in-law, she had a breast cancer, and then 20 years after, she had it again.
Yep.
But what I don't understand is that the first one, she had radiation, and when the second came, the doctor said, you can't have radiation again?
So it came back in the same breast?
Yeah.
Yeah. So your breast, your tissue, and it goes to the question about the radiation earlier, your tissue can only have so much radiation because you want to have enough to kill the cancer cells, but you don't want to kill the normal cells. But, and so if you re-radiate, that's going to be, the tissue's not going to be able to tolerate it. So that's why if it came back locally in the breast, they'd have to remove it, maybe not the breast, but at least the lump or the area of it. Now, when it comes back in another organ, those cells are already out, but it could show up 5 or 10 years later in your lung or your liver or something like that. Then those are cells that have been asleep for 5 or 10 years. So that, what we really have to figure out right now, we blast them with chemo, but what we really need to figure out is what put them to sleep and how can we keep them asleep longer? Because really, you don't care if they're asleep. They can hang out, but what you don't want is for them. So what you want to do is be able to keep them asleep. And there's a study that's just starting that we may be collaborating on, looking at what they call tumor dormancy, which is keeping them asleep and trying to figure out. And there are some hypotheses out there in the public that may not be so crazy, that a big stress or something like that, which changes your immune system, actually can allow them to wake up, that maybe your immune system's keeping them, down, and then people will talk about, oh, this thing happened, and then all of a sudden my cancer came back again. I mean, we really haven't looked into those kinds of things very much, and I think that we really need to look into. There's some evidence that even having surgery, if you may awake your immune system, because it's obviously an assault on your body and can increase recurrences. So there's a lot of research that you'd think that breast cancer is so ubiquitous, we'd know everything, but there's a lot of research that's not being explored because it's just not sexy enough. Yeah.
So you talked a lot about how the treatment of breast cancer over the past 30 plus years has evolved. Has the cancer evolved?
Well, okay. I'll put it this way. Our understanding of the cancer's evolved. Now, whether that's because it's changed or because we've changed or both. And even now, the people are talking, you hear about precision medicine. And it's how we're going to figure out exactly what mutation and what cancer and get the right treatment to it. But it's turning out that the cancers are actually not all the same. They're a mixture. So if you knock down one group, then another group could rise up, so it's not quite so clear that precision medicine is going to be the answer. And the other big thing right now is circulating tumor cells. So this is where we get the technology before we have the understanding. So we have the technology that we can detect either DNA or cancer cells in the blood, just when there's a couple of cells or there's DNA floating in the blood. And the idea is, therefore, that will tell you what kind of cancer you have, what flavor, and it'll also tell you whether you've treated it accurately or not. But in actual fact, we haven't proven that yet. So it may be that the cells that are circulating in the bloodstream or the DNA in the blood are the ones that can't get into another organ. They got on the 405 and they can't find the exit. And so they're just driving back and forth on the 405. So we're assuming that those cells are on the way somewhere, but we actually haven't proven that. So we have to just be cautious. Sometimes we get overexcited. Yeah.
I
Yeah.
can kind of a little bit just answer this question, but we all get physicals once a year and we get our blood drawn. And so if you're saying that these DNA or these cells can be detected in whatever, the blood test, why isn't that just something that everyone?
Because it hasn't been proven yet. Yeah. That's the hope that, that's what people are, and there are a lot of startups that are looking at this, trying to, but I'm old enough that I've seen these hypes, not work a lot of times too. So I think it needs more work before we really know, before we're really going to be able to say. Now, some of them, there's the nasopharyngeal cancers, they actually, because that's a virus that they've actually been able to, just recently, there's a study that showed that they're able to pick that one up. And that's common in some of the Asian countries. And so that may be good. But I'm not so sure this circulating DNA is gonna, there was an old song about the guy who couldn't get it off the subway because he needed an exit ticket and he never returned. No, he just kept going around and around and around. I think that's what those cells are doing. I'm not sure they're the ones. I think the smart ones already got to the other organ, and that the ones that are hanging out in the bloodstream may be the rejects that don't know how to spread. But we don't know that yet.
How closely related are there certain cancers that are more closely related than others?
Yes, and there are, well, in a general sense, there are cancers that start in glands called adenocancers, and there's cancers that start in surface like skin cells, that's epithelial cancers, and they tend to behave differently. And then even within, say, breast cancer, there's different flavors. So some of them are sensitive to hormones, some of them are not sensitive to hormones, some of them have something called HER2/neu, which always sounds to me like something you should put on your hair, but actually is an epidermal growth factor and tells the cell to grow faster or stronger. Then some of them are called triple negative, which is a particularly poor choice of words because it sounds really bad, but it just means your hormones, estrogen, progesterone, and HER2 are all negative. That the 3 tests were negative, not that the cancer is negative, but we don't always think about our branding very well in medicine. And so what you can do is figure out what flavor you have, and then the idea is that you match the treatment to that kind. And that works some, but it's turning out that they're not homogeneous. So the whole idea of precision medicine may not be as precise as we had hoped. And if you knock down the dominant group, then the other groups can come up. Yeah.
Back to the idea of mapping and
Yeah.
lack thereof.
Yeah.
I'm curious with all of the 3D mammography and the sophistication and the seeming sophistication of some of those
Yeah.
Technologies, why they couldn't do something like a contrast dye when they're doing a 3D mammography of someone who has cancer or maybe someone who's
Right.
preventing. Is that too simplistic?
Well, you could, yes, but you'd have to do it down the ducts. So either that or you have to find something that, and I haven't really thought of, that would be concentrated in the ducts. So that, because when we do a contrast dye in the blood, it's going to stay in the blood. It's right. So the ducts are separate from the milk ducts are separate from the blood. So that the other way would be to squirt it down ahead of time.
Yeah.
And we're gonna, I'm actually talking to some people at Harbor, and we're probably gonna do that for people with DCIS where it's in one duct. We could squirt it down that duct, and then you'd have a map of that duct when you did the surgery. So that
Yeah,
you,
'cause I think when you were saying that the sort of miracle of women's bodies, so breastfeeding mothers can turn blood into milk.
Right.
Actually, wouldn't that therefore be possible with the same kind of
to turn something,
from
yeah, it might be, but the problem is the ductal fluid doesn't totally match the blood. So that obviously there's some filtration and stuff that happens, but there is some fluid in the duct. So if you're not breastfeeding, there's enough fluid so that the duct doesn't stick together, right? There's like a little bit of fluid, and you can do something to wash it out. In fact, we did some early studies. I invented a catheter that you could put in the duct and you squirt in salt water and then you suck it out. So ductal lavage, we called it. And we actually started a company, and it was gonna be in instead of mammogram, and then the company was bought by a mammogram company that killed it. But the interesting thing is the ducts are different too. When we did 3 different ducts and looked at hormones and cells and analyzed the stuff, and they don't match. So and you only get cancer in 1 duct. So what we really have to do is figure out how we can either make the ducts secrete by themselves, and then we could test all the fluid. And if it was abnormal, then you could go duct to duct. That might work.
Right, yeah, and I guess the next level of that thought-wise was, well, if it's typically the outer ducts that tend to get the cancer, then wouldn't it be seemingly a good idea to try doing that like on isolated outer?
Yeah, it's if you look at big studies, it's more common in the upper outer quadrant, this part. But all the ducts can get cancer, even the middle ones can get it. But if you have something on a mammogram, so sometimes when those cells are crowding the duct, like rust, they'll calcify. And you can see on a mammogram little specks of calcium. So they call that microcalcifications. And if we have a map, we could say, oh, those microcalcifications, they're probably in the middle duct, here, and then and squirt something down and do it. So that's doable, and that's what we're going to try to do over at Harbor. But it's a big deal to do these kinds of studies because you've got to get all these permissions and all this stuff, and then you've got to not just for the patients, it's the review boards, and the hospital wants a cut, but the patients actually I've found are more than willing to be. Women are very altruistic, and they're perfectly happy to be part of it. But it's getting all the other parts going. Yeah.
This may be a question that's not related directly to the science, but it seems crazy that the radiologist, it's almost like a politically driven decision not to get early detection devices at scale like you're doing in Mexico, if I'm following that correctly, or Mexico?
Well, so in Mexico, we're doing triage, right? We're going to triage lumps. So you already have a lump and we're going to triage it.
Right.
That's yes, and there's a growing war. The thing about mammography screening is, yes, it can find some cancers early. It misses a lot of cancers, and it also, as well, and it's radiation. And so it's not really that valuable in younger women, premenopausal women, as it is in postmenopausal women, partly because when you're premenopausal, your breasts are at the ready to make milk and get pregnant at any moment, and they're denser. And the x-rays can't see through the density, and dense breasts make the x-rays less accurate. Once you go through menopause, then your breasts go into retirement. They don't have to make milk, they turn to fat, and then they're really easy to see through. So one of the reasons that mammography isn't done in younger women is not because we don't like younger women. It's because it's just not a very good tool, and you get radiated without much benefit because you get the radiation and it's really not that accurate. 3D ultrasound is probably better if somebody is at high risk because that doesn't have any risk to it and might be able to find things. The problem with MRI, which is yet a whole other, is that it finds too many things. I mean, it finds a whole lot of false positives. So you end up with a lot of biopsies that really you didn't need to have because it's too sensitive. So, so that's where the 3 things.
But I guess I get why Mexico? Why can't we test the devices here?
We did test it here.
Okay.
We tested it here at Harbor at the county hospitals in LA, which are like a low to middle income country in terms of population. But the grant we have says you then have to show you can do it in a low to middle income country. So we have an NIH grant, so we're fulfilling that by going to, and I don't have to fly away to Africa. I can go to Mexico. I can faster, easier, and I speak Spanish, so it's better. So we're doing that in Mexico. But the idea would be ultimately that you should be able to have it anywhere, but we've got to convince the ultrasound companies. I was just using that to show how difficult it is because they are fairly short-sighted, these big companies,
Well,
about
politically driven. I don't want
who their customers are. Yeah.
It just seems like there should be an escalation process when the people that are fighting against it, because it means their business is at stake, are not supporting innovation, right? So
Right.
is there in the medical industry an escalation process?
Yeah, no, and I think the way to do it is to take it to somebody else. So give it to that's why I was saying, you go to the gynecologist. Young women, premenopausal women, that's where they get a lot of their health care. Gynecologists are really good at ultrasound. They do it, do it for babies and all that stuff. So give it to them for the palpable ones. But, there's a lot of people along the food chain in that, you've got not only the radiologist, then you have the surgeon who then does the biopsy, then you have there's a lot of people in the food chain that you're disintermediating and they don't like it. So, so it's a little tricky. And that's why in some ways going to an LMIC country is a way to get around it and then have it filter back.
This might be a really stupid question. but
There's no stupid question.
What are your thoughts on birth control taking additional hormones in relation to breast cancer?
So birth control does not increase breast cancer. Okay, that's been shown. There's some big studies. So that in terms of breast cancer, because you're really in some ways you're taking a set amount of hormones every month. They're the same hormones that you would have anyway. And when you're just left to your own devices, your hormones are probably not that regular. They might be higher one month and lower another month. So in some ways, birth control. So that isn't a problem. What is a problem, and taking hormones at menopause to get over the hump, there's about 2 or 3 years at menopause. It's sort of like puberty in reverse. With puberty, your hormones are all over the place. Well, they're all over the place again. And you could sort of even that out. But taking them long term, like for the rest of your life, it does increase breast cancer. And at one point, we had a woman head of the NIH, the only time we've ever had a woman head of the NIH. And she did the big randomized control that answered that question, because at that time they were saying women weren't supposed to live after menopause. We were all supposed to die at 50, and that we were artificially alive, and therefore we had to take hormones to keep us. That was really, it was a bad. I got into a lot of trouble then because I was against it, and Malcolm Gladwell wrote an article about the New Yorker, "How Wrong is Susan Love?" And I turned out to be right, actually, but. Anyway, but so that's what's up. But the birth control pill itself is okay, especially the low doses that they use now. Yeah.
I know you mentioned CAR T cells
Yeah.
briefly, and both my parents worked at NIH for 40 years.
Aha.
I love immunotherapy, and I think it's a really fascinating development.
Yeah.
I know that NIH has been working on it for decades, as have a lot of other institutions. How close do you feel like we are to figuring out that perfect balance with immunotherapy for cancer?
I don't think we're quite there yet. But in a way, I had leukemia 5 years ago. I had AML, and I had a bone marrow transplant for my baby sister. And that's the ultimate immunotherapy, actually, because you change your blood type. I have her immune system now. I have her allergies. If I had gotten it from my brother, my blood would be XY chromosomes, and the rest of me would be XX. But at any rate, so we have a lot of data on that kind of immunotherapy. The problem with CAR2, at least in breast cancer, now they have some CAR2 cells. These are T cells, which are a form of white blood cell, and they hooked onto them an anti-HER2 because HER2 is an epidermal growth factor that is common in breast cancer. And so they gave it to somebody who actually had metastatic breast cancer. And it turns out you normally have HER2 in your lungs, and she died of pulmonary disease. And so it killed her. So now they're trying to figure out how to do it more precisely. That's why we were thinking maybe we could put it down the ducts, because there's HER2 down the ducts. And if I can hook it to something so I know it stays in the ducts instead of diffuses out where it can get into trouble, that may be a really cool way to prevent breast cancer. So that's what I'm trying to think of right now. So we'll see, but that's what we're working on figuring out. Yeah.
I'm wondering if you have an opinion or thoughts
I have
on
an opinion on everything.
Amazing, because I would love to hear it, on the CHEK2 gene, because my mom is one of 4 girls, including my mom, who's had breast cancer. I'm one of 3 girls, and what they've told us they feel like is the common denominator is the CHEK2,
Right.
which I've tested positive for.
Okay.
So I'm on 6 months. Do you have have thoughts on that?
So, well, let's talk a little more broadly in people who have a mutation and because yes, it increases your risk, but you probably need more than just an abnormal gene to get it. Because not everybody with CHEK2 gets it, not everyone with BRCA gets it. So obviously you probably need a mutation and we don't know what the "and" part is the problem. Now, what we need to do really, right now we don't have very good prevention. So the prevention is, cutting your breasts off or taking your ovaries out. If you take the ovaries out, you can prevent both breast and ovarian cancer because the breasts, you put you into premature menopause, but the breasts aren't stimulated. And if you just take the breasts off, you can reduce breast cancer. But it's a pretty drastic thing to do. So I think the decision ends up having to be depending on how easy is it to image your breasts, and how all these things. If you had really dense breasts, if everybody in your family got it really young, all the factors that might push you one way versus another way. Angelina Jolie had the BRCA gene. She had a mutation that made her high risk for breast and ovarian cancer. And ovarian is worse because that is much more likely to be fatal. And so she had if you have your ovaries out, you also reduce your breast cancer risk because you're not exposing them to hormones. And so she had her ovaries out and then she had her breasts off as well. And people didn't and her mother had died of ovarian cancer. So it made perfect sense for her to do it. A lot of people then rushed off and did it, who probably were not in the same situation she was. But it's a very tricky situation because now we're better at predicting who has this high risk, but we're not so good at figuring out how to fix it or prevent it. So it's not like there's no good answer to the question. So either close monitoring, and they often use MRI. Because yes, it's too sensitive, but if you're in that situation where you have a gene that makes you high risk, you want something that's too sensitive. So there, it makes sense to have it.
I know that we're a little bit over time, but I think you're staying a little bit after to sign books.
Yeah,
And maybe
yeah.
people have rounded questions. But thank you
Yeah.
everyone for coming.
Thank you.
And the books are over there. They're for everybody. So first come, first serve.
Sorry.
I know. You can follow him on Instagram.
Sorry, your dog also.
I
I have a bunny and my bunny has a YouTube channel.
Yeah, I have a.
Let's see each other.
Yeah.
I want to talk to you all about
It's just right. Oh, you're welcome. Does that mean that yeah, or, no, it's exactly the same. It's a one that compares. It's really, so I think that she's.
was just saying how I should have made the block.
Yeah, but for her, we.
Good, good.
So.
Yeah, then I got.
Yeah.
My apologies.
Of course, Title IX, Title IX, of course, children.
That's good.
If you make federal money, you can't have it. So they just-
Yeah.
Like at any rate, so I was.
I think that they should. Oh, yeah, I'm doing your workshop.
Kids out.
Hey, what's going on? How you doing? Nice to see you. Nice to see you too. Great, day, huh? How have you been, Dee? Pretty good? Nice, nice. Definitely, set up some seats, yeah. Okay, Carolyn, 2 seats. Set up time. Half an hour, catch up on things. Yeah.
Yes, 3/4. Finish the chair, sell it on.
We had like a team all day meeting and I was like, well, I didn't get that day, but I have at least an hour to do this. And they're like, okay, well, I don't know. So like, based on like the agenda for the day.
I just did the physical therapy, it was fun. And so a lot of this stuff, there's very little randomized data, I mean, there's very little data. The data is just, oh, well, I had a lot of patients when they got better. But not randomized.
Tanya is like more.
T-O-T-A-N-J-A.
I'm just saying, she was like, I love to see it.
Well, I need money to make it happen.
So,
You don't need ads. To make it into an ad. I have the grant, but it didn't include making an app to put on there.
how much are you?
Yeah, well, I don't know, the researcher I had. With the AI said.
Oh, really?
That's what it is.
Oh, she's out of town.
Yeah.
I'm just gonna go on Sunday. That's so funny.
She's doing a yoga retreat. Were you with her?
I don't think I need that much either. No, I'm saying the person, the engineer that was, that we've been working with on the original.
Yeah, I think we're gonna go.
That's what's for us. And then we just need, but I don't think it's probably.
That would bring you, because this is really research and you can for cancer. You were. Yes. In socks, like. I don't know what it's.
Exactly, I just don't know.
Abby was like, yeah, I'm sorry. I'll be you guys in like
Yeah, well, that's what I was thinking. What about, mass don't do it, it would just have your. Space Caps, how many was it on? And it's 9 times.
all like keep breathing.
Yeah.
Or milk and the.
That's all over. Really?
my whole world. Mom was there. Okay, with my dad after.
I read to your parents at the airport.
I know, they literally went to the airport. and
Yeah.
They're like, going to the same place.
Yeah, I was like, funny.
My mom was saying,
Yeah, exactly.
I wouldn't know.
I
I
know.
know, like,
Yeah,
yeah.
during
But
the
this next one's for me.
I'm already not here. But actually,
Thank you so much for being here. This was
awesome.
awesome.
They usually are, because they usually like.
Yeah.
Fine.
Great questions.
This doctor,